This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 952, recorded on November 4th, 2022. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from Ann Arbor, Michigan, Kathy Spindler.
Hi, everybody. Here, it's really nice. It's 70 degrees, but we have some rain coming our way. So that's 70 Fahrenheit. And on the Your Rain Norwegian weather app, that tells us it's 21 Celsius.
Yeah, exactly the same here. Mostly sunny, 21 C. Also joining us from Western Massachusetts, Alan Dove.
Good to be here, and I actually have warmer weather. It's 22 C, wow. 72 Fahrenheit. Gorgeous, clear, blue skies. We had a really, really thick morning fog that stuck around till about almost 11. Then that finally burned off, and now it's
And from Austin, Texas, Rich Condit.
Hey there. 80 degrees, mostly cloudy. I had some rain this morning, which is awesome. Little drizzle this afternoon. It's going to be a beautiful day tomorrow.
Our guest today is out at Stanford in California. He's a professor, clinical professor of medicine, infectious diseases. Jake Scott, welcome to TWiV.
Thank you so much. Great to be here. It's 55 degrees Fahrenheit here, which is about 13 degrees Celsius. So it's colder here than where you all are.
Wow.
It's been partly cloudy, and we've finally got some rain here in the Bay Area. So, but it's chilly.
All right. So before we get started, I want to tell everyone that since our first announcement of the Spike Shirt fundraiser back in September, many people have bought shirts and expressed their support for the making of the vaccine.
There's Rich.
Oh, there it is. Look at that shirt. Nice.
For the audio listeners,
Beautiful.
Rich is standing up and showing that he's wearing the
Spike. It gave me an opportunity to tell my daughter all about protein structure.
Nice.
The other day.
It's a good fit.
Mm-hmm. So Spike T-shirts.
They're great.
The people at vaccinated.us have generously agreed to give us some of the profits from these shirts. So we did September.
And these are in no way similar to hair shirts.
These are we did September, then they extended it through October, and now Matt over at Vaccinated decided to extend it through the end of the year. So we're really appreciative. Cool. These are shirts for men and women and kids, different colors. So please celebrate the molecule of the year, spike protein of SARS-CoV-2, and at the same time you support science education at Microbe TV. Go to vaccinated.us, buy the shirt, put it in your cart. Then when you go to checkout, use the promo code MicrobeTV, all one word, no periods or anything, MicrobeTV, and that will make it known to the people at Vaccinated that the profits should go to us. And I have to say that Jake, I really appreciate it. He's doing a lot of work because people forget or they don't put the code in. He has to go in by hand and fix it. So I'm really appreciative of Matt, who happens to be in Seattle, and I was just there for only 2 days, so I missed him. But thank you so much for your support. Now, Jake was referred to me by Jeff, who works with us, trying to raise funds. And he said, you should have Jake on TWiV. So here you are. And let's start by having you tell us a bit about your history. Are you from California to begin with?
Yeah, I grew up in California in Marin County, Sausalito. And I spent most of my life here. I went to college in Santa Cruz at UC Santa Cruz.
Whoa! I was in the second graduating class.
Oh, really? Wow.
Yeah. When did 70? You graduate?
90.
That would have been 1970, yeah.
Okay. That was 2000. I should have been 99, but I took a year off.
What college?
Cowell.
I was in Cowell. Did you ever stay in the dorms?
I did, yeah, in Cowell.
What house?
Prescott.
I was in Morrison House.
You guys remember a lot of stuff.
Awesome.
Yeah. So I'm from California. I went to Santa Cruz and it's funny. I was just thinking how crazy it is that I'm on this podcast, because when I was a kid, I never really got into science and math, science in particular. I kind of avoided it, to be honest. And when I was at Santa Cruz, the only science prerequisite that I did was life in the sea. My math requirement was fulfilled by oceanography. And I was really into surfing and kind of aimless. Eventually majored in literature with a concentration in creative writing. And I got really into critical theory, critical thinking, doing close readings of texts, etc., which I was thinking of recently when you guys were talking to David Quammen. I think Rich brought up the value of critical thinking when it comes to doing and interpreting science. And so I think that was a good experience for me. And then after college, I really didn't know what I wanted to do. I taught English in Japan, lived in Tokyo for a year. And then I ended up back in San Francisco and randomly got a job at a Planned Parenthood here. And it was an incredible experience. Then I started volunteering in public health, so at a syringe exchange in the Tenderloin and in the ER at San Francisco General. And that's what really got me inspired to go into medicine. So then I had to hunker down, and I did a 2-year pre-med post-bac program at Mills College, and I loved it. And I was pleasantly surprised by how much I enjoyed the sciences, and I've been passionate about it ever since. And then I went to the University of Vermont for medical school. And then I did my residency in internal medicine at Kaiser Oakland and my fellowship in infectious diseases at UCLA.
So it's interesting. You got excited about science later on. This sometimes works that way. It's good. Do you speak Japanese at all?
Well, that was almost 20 years ago. I speak some. I can make small talk.
Yeah,
I can order food. Yeah.
You can order food. Wonderful. All right. So when did you decide you wanted to do infectious diseases? Is that something that came along?
Yeah, I became interested in HIV when I was volunteering for a syringe exchange and working as a test counselor at a Planned Parenthood. So that was back in 2002. And then in medical school, I was drawn towards infectious diseases. And I think some of it had to do with just my interest in stories. So much of infectious diseases it involves sort of getting the story behind a diagnosis. And we focus a lot on interviewing patients, which I just found to be really, really satisfying. So, I try to sort of look at the patient's history as sort of a narrative arc, and loved how we could make diagnoses just simply based on asking the right question sometimes, and not relying on $1 million worth of tests. When I was a resident, one of my very first rotations was in infectious diseases, and we had this fascinating case. A guy had been on Long Island for a vacation and came in quite ill. And he turned out to have babesiosis and anaplasmosis, which are tick-borne. And had we not asked about his travel history and looked at a drop of blood under the microscope, we wouldn't have made the diagnosis as quickly as we did, at least. So, yeah, and then throughout residency, I was totally obsessed with infectious diseases. And, I always thought the cases were the most interesting.
It's funny because yesterday, Daniel and I recorded a TWiV at ASTMH in Seattle, and so we had a guest who was a physician, and she I'm asking her questions, and Daniel said, sometimes I think you're an infectious disease physician, Vincent, because we do the same asking questions, right, as you just described, Jake.
Yeah.
So
there's an art to it.
Tell us, what's the job of an infectious disease physician? Where do you work and what do you do?
Yeah, great question. So I work at a hospital. I also work in the office. And I'm glad that you asked that, because I think there's a common misconception that infectious disease doctors only deal with contagious and rare diseases. But most of what I do, the majority of my work is spent in the hospital, seeing patients who are hospitalized with a variety of infections. And most of these infections stem from, say, bacteria that got into the wrong place at the wrong time. So diabetic foot infection is one of the most common things I deal with. Pneumonia, meningitis, tuberculosis. In the office, I see a fair amount of HIV, a lot of recurrent urinary tract infections, fungal infections such as valley fever, all sorts of things. So just any sort of infectious disease. And so I work as a consultant in the hospital. I'm a full-time clinician, essentially. I'm involved in some research and other projects, but I'm essentially a full-time clinician. And I'm asked to see primarily by the ER docs, ICU doctors, and hospitalists to see patients who are hospitalized with either a clear-cut infection that requires antibiotics, or they often consult me for just helping out with the diagnosis. And oftentimes it's not an infection. Sometimes we help diagnose cancer, for instance.
So, are you part of a team? Is there a group of infectious disease docs that you hang out with and compare cases and notes with? So there's more than one head on a problem.
Yeah, no, there's a large division, Stanford Infectious Diseases Division, and we, regularly meet and present cases and talk about, patients. And then I have two infectious disease colleagues that I work with here at our hospital in Pleasanton, which is called Stanford Healthcare at Tri-Valley.
So an infectious disease doc that does not have a private practice, right? It's always working in a hospital, correct?
No, there are a lot of private practice infectious disease docs. Yeah.
And they would be engaged by other docs as consults, right?
Right. So I've got sort of a hybrid position where I work in a hospital that's, as kind of in a community setting. We serve a really large area, but I'm also involved in academic work and involved in some teaching. But my main passion is patient care and especially in the hospital in patients.
Okay. So we're here to talk about COVID with you. So have you seen COVID patients? Stupid question. But how many have you seen, would you say?
Boy, that's a good question. I've actually kept track. And I haven't tallied all of the COVID patients that I've seen from the beginning, but it's been thousands. So, but the reason why I looked at some of the more recent data that I had kept track of was because since January of 2022, I've hardly seen any COVID patients. And out of the last 246 consults I got, new consults for unique patients in the last 8 months, guess how many were for COVID?
I'm going to guess zero.
Two.
Close.
Yeah. But those two essentially didn't even need to be hospitalized and were discharged within 24 hours and didn't require any oxygen. So in 2020, I had hundreds of COVID patients, and most of them were critically ill. Mm-hmm. I lost probably well over 100 patients to COVID, and so it's been the pandemic, from my perspective, has dramatically changed, and I really cannot emphasize how much different things have been since Omicron hit in January.
Have you had, since January, you've had two COVID patients and they went back out. Is this pretty similar among your colleagues? Are they?
Yeah, great question. So it is similar to what my colleagues are reporting. And, I remember a few months ago, I share an office with one of my partners, and I said to him, when was the last time you saw a severe COVID pneumonia patient? And he couldn't remember, and I couldn't remember either. And it really hit me that, this new reality is not, I don't think, being recognized, at least in the public. I think there's a big disconnect between the clinical perspective from those of us, on the front lines, and the public perception. So I've been talking to a number of other colleagues to see if they've had similar experiences. So colleagues in LA that I've known from fellowship, colleagues in Canada, colleagues in Australia, and all of them are saying the same thing, that they can't remember the last time they saw someone with severe COVID. And by severe COVID, I mean COVID pneumonia, which before Omicron hit was very, very typical. And the presentations were very consistent. So on the x-rays, they had bilateral ground glass opacities and consolidations. They had markedly elevated inflammatory markers. They often required a lot of supplemental oxygen. A lot of them deteriorated really rapidly and required intubation, ventilation. That's what I call severe COVID. Mm-hmm. And I haven't seen a single one of those cases since the end of Delta. And Delta receded December and January. And I've talked to over a dozen colleagues from around the world who've said the same thing.
So do you think that's because of change between Delta and Omicron? Or is it at all related to the kinds of populations that you and the colleagues that you've talked to see? For instance, if you went to some rural place in America or Canada or Australia, would it be a different story where maybe it's not as progressive as California?
Great question. I do think that it's multifactorial, but that there is an intrinsically reduced risk of severity associated with Omicron. And, there were reports of that back in December. I remember when there was a preprint by Hui and colleagues from, I believe, the University of Hong Kong. And they did, do you remember that? They did, it was eventually published, I forget where it was published, but they did ex vivo cultures from bronchi and do you remember that? And they found that Omicron replicated much more efficiently, essentially, in the upper respiratory tract compared to the lungs. And it replicated less efficiently in the lungs, so tenfold less in the lungs and around 70-fold more efficiently in the upper airways, which I think could explain why it was more transmissible, perhaps, just because, when you're speaking and breathing, you've got higher, titers, you might be more transmissible. But I think it also explains why we're seeing, and we've consistently seen, essentially no lower respiratory tract disease. So I think it's Omicron. I think it's obviously changes in population immunity, of course, and that's huge. But there have been a number of studies, epidemiological studies, since some of those more biological studies, that have also consistently shown a significantly reduced risk of hospitalization and death associated with Omicron. So 60 to 70% reduced risk. So I think. Yep. Go
ahead.
No, I was just going to say I think it's multifactorial, but I do think that the differences that we've been seeing with Omicron are not being acknowledged widely enough, and I think that a lot of ID docs are sort of timid about coming across as minimizing COVID, which is the last thing we would want to do after what we've been through and what we see some patients continue to go through. So I mean, I remember it was kind of taboo almost to consider Omicron to be milder. Remember, but
Daniel didn't really buy into that, right? He said Omicron can kill you, right? So
yeah.
The 500 people dying in the U.S., right? It's Omicron.
Yeah.
So
I'm
trying to imagine what sort of selective pressures would result in, this apparent, in italics, apparent change in phenotype. I'm wondering if, sort of even the changes in spike could change somehow receptor affinities or affinities for receptors in different tissues, or maybe changes in other proteins that affect better replication of the upper respiratory tract, have the effect of compromising the replication of the lower respiratory tract. I'm just riffing on this because it's hard for me to imagine selection against specifically replication in the lower respiratory tract, though maybe I'm not thinking of it right.
Yeah.
Well, you've probably.
Well, it's probably just a trade-off where if you're better adapted to one set of cells, you're probably worse adapted to another set of cells, and so you end up and those traits. Since as Jake just said, this is most likely one of the reasons that this spreads so well, and the Omicron spike in infections just dwarfed all previous spikes in infections and was in the wastewater at ridiculous levels. And so the thing gets around, and that's the advantage. Then the disadvantage is it can't get into the lower lung. But
I think a lot of the changes that make it
necessary.
immune evasive could, Rich, make it do less well in the lower tract, right?
Yeah.
But I'm puzzled, and maybe a regional thing, because there are 500 people dying a day in the U.S. They're dying of Omicron, right? And Daniel says they're unvaccinated, over 75, or immunocompromised, right? So in the right population, it could still kill you, right?
Well, so here's what I've been seeing, and when I say that I've only been consulted to see 2 COVID patients in the last 8 months, that's not to say that the hospital has only had 2 COVID patients. The hospital has had many, many more, but almost all of them have been incidentally positive. We check PCRs on admission, and as most people know, PCRs can remain positive for a long time, right? So incidentally positive and mildly symptomatic patients who were admitted because, maybe the fevers associated with COVID led to dehydration, which led to a near fainting episode that required going to the ER for IV fluids and being discharged, the next day. Or maybe it led to an inability to consume enough fluids or from nausea and vomiting associated with Omicron infection. Oftentimes, Omicron infection, just like any other viral upper respiratory infection, can precipitate a congestive heart failure exacerbation or a COPD exacerbation and lead to hospitalization. So those are the patients who are being hospitalized, and I think those are probably making up the majority of the COVID deaths. Because pre-Omicron, what we saw was acute respiratory distress syndrome, ARDS, caused by terrible lower respiratory tract disease, clearly caused by COVID and oftentimes only COVID. A lot of these patients didn't have, concurrent bacterial pneumonias or anything like that. They had straight COVID, which led to respiratory failure and death. And it was awful. It was the most terrible experience of our lives as clinicians, so I certainly don't mean to minimize it, but it is dramatically different these days, and I can't emphasize that enough. And to go back to Kathy's question, some of these studies that have been high quality studies, so there was a Kaiser Southern California study, and there was a UK study of Omicron in risk of severity. And they also found that this was the case in unvaccinated people, that there was a significantly lower risk of death associated with Omicron in unvaccinated people. So 86% reduced risk of death in one of the studies.
And you said before Omicron, Delta, and previously, those were all more severe in your experience, right?
Oh, 100 times more severe. It's hard to quantify, but yeah. So in 2020, especially in the winter of 2020, I was, we have a lot of nursing homes in the area, and we were seeing multiple nursing home residents admitted every day. I probably lost over 100 in just a month or two to COVID, And then in 2021, after the vaccines were rolled out, there was a dramatic drop-off in the number of nursing home residents in particular that were being admitted, at least to my hospital, within just a few weeks of the vaccines being rolled out. And that was, mid-January. And then throughout the rest of 2021, what I mainly saw were unvaccinated people with severe COVID. And I saw a lot of younger adults in their 30s and 40s who succumbed to critically ill COVID, and many of whom died. And then throughout, the Delta wave, it was devastating. And a lot of hospitals were overwhelmed with just severe COVID. ICUs were packed. There was a period of time where we always had at least, a third of our patients in the ICU were there because of COVID. And we haven't had a COVID patient in the ICU in months that has been there for COVID. That's not to say that Omicron infection in someone who's fully vaccinated and boosted can't lead to an exacerbation, like I said, of an underlying medical condition that then requires hospitalization and sometimes leads to severe outcomes. But that is the case with other respiratory infections as well. Rhinovirus was shown in the EPIC study to be one of the most common causes of pneumonia, and that included bacterial pneumonia as well. So it's very different.
Right. So, it seems like what you're getting now are the 500 deaths a day statistic that we see is people who died after a series of events perhaps precipitated by a SARS-CoV-2 infection, but it was not the virus that killed them necessarily. It was the sequelae of it.
Right. That is my understanding. I certainly don't think that all of those patients are succumbing to severe COVID pneumonia and lower respiratory tract disease caused by COVID. So again, I haven't had a single patient die from COVID this year. And a lot of my colleagues say the same thing.
So if we were testing as much for the other four common cold coronas and rhinovirus and adenovirus and all of the other chest colds and head colds that somebody could get, if we tested as rigorously for all those as we do for SARS-CoV-2, maybe we would see 500 deaths a day from rhinoviruses and 500 deaths a day from, adeno.
I think that's a good point. But, another big difference between COVID and those is COVID is still rampant. Right. I mean, the levels of SARS-CoV-2 in the community around the world are dramatically higher than any rhinovirus outbreak. So it's both. It's that we are we're testing so many people. We continue to test every single person admitted to the hospital. So, of course, we're going to find a lot of positives. And a lot of the people who have positive tests have zero symptoms. So, yeah, testing is part of it, but it's also because there's just so much COVID circulating.
What do you think is the baseline percentage of positives in the community? Do you have some idea?
Oh, it fluctuates. Baseline, 5-10%. I'm not sure.
Okay, it's a lot.
I wonder what the end point is. I wonder when we decide that this is just actually no different than a rhinovirus or a coronavirus. Any thoughts on that?
Yeah, great question. There was a piece that came out, I believe it was the BMJ a few years ago. I forget the author's names, but there was a great quote about how the pandemic won't end. I'm totally paraphrasing here. The pandemic won't end when the dashboards all turn to zero. Right? The pandemic will slowly sort of fade away as people go back to their normal lives. And there's not going to be, even though Biden said the pandemic is over, there's not going to be a final, conclusion based on certain metrics having been met. I think that, initially the dashboards were very helpful, in 2020. But I think that we need to recalibrate our goals because, and I also think that we need to question the accuracy of these metrics that are being reported on these dashboards. Because things are just fortunately dramatically different. And that's my point. It's not that, COVID is nothing to worry about, that COVID is totally insignificant, but it's different, and we should be extremely grateful. I mean, I can't tell you how much better things have been for me and all my colleagues.
So just to get back to Alan's point, I wonder if we tested as much for common cold coronas, if we'd see rampant common cold coronas in the community, right? Because we don't test.
I think we definitely will. I mean, I think we definitely would, and I think that if we stopped testing as much, we certainly wouldn't be as worried.
Yeah. Well, there's another elephant in the room, and that's long COVID. I want to get to that, but first, you've heard Paul Offit probably on TWiV, right?
Definitely.
So you know his stance on the bivalent boosters. I'm wondering what are your thoughts on that?
I agree with Dr. Offit in a lot of ways. I think that he's made some very valid points. One is we don't have enough data on the clinical benefits of the new boosters compared to the old boosters. The data that I have seen that has been made available have been underwhelming, I'll be honest. So, there was a neutralization assay study that showed that there was only a 1.5-fold difference in comparing the bivalent to the monovalent against BA4/5. That I don't think is clinically significant. So we'll see. But I one thing that I appreciate about Dr. Offit is that he knows very well how delicate vaccine confidence and skepticism is, and how cautious we have to be. And it's so important, I think, that we don't oversell boosters. And I think that we have to recognize that booster fatigue can have sequelae. It can lead to fatigue of other vaccines as well, and it can lead to booster uptake has been poor, and I would hate for that to sort of spill over into the uptake of other vaccines. So in terms of the bivalent booster, I recommend it to certain populations, older populations, and to immunocompromised patients, just as I would recommend the monovalent booster. I only recommend the bivalent booster because it's the only one available. Yeah. But for people under 50 who don't have any medical conditions, I think that people should take it on a case-by-case individual basis. I mean, my job as a physician is to give people information so that they can make the most well-informed decisions for themselves based on the risks, benefits, and alternatives. So.
All right, so let me give you some clinical scenarios. If you have all these people have 2 doses plus a boost, right? And now you have a 30-year-old comes in with symptomatic COVID. Would you do anything to that person in terms of treatment?
I would personally recommend supportive care, symptomatic treatment. And as we were talking about earlier, some of the antivirals I think are going to be helpful for certain populations, but we do not have high-quality randomized controlled trial data that clearly shows that Paxlovid provides benefit to vaccinated individuals. There are observational studies that have shown that Paxlovid provides potential benefit to certain patients or individuals over a certain age, like over 65. But for someone under 50, I don't recommend any antiviral. I provide reassurance and recommend supportive care.
So for a 60-year-old, you would recommend Paxlovid or monoclonal, I think you said before, right?
I would mention these as options, and I would just kind of go through the risk and the benefits and the data on a case-by-case basis.
Yeah.
But, I also try to reassure people that regardless of whether or not they take an antiviral, they're almost certainly going to do just fine.
Yeah.
If they are going to develop a complication, it's going to be maybe a secondary bacterial pneumonia or bronchitis or asthma exacerbation, which I don't think an antiviral would necessarily prevent. And the antivirals have to be taken, promptly, of course. But I think for the most part, people are going to do fine when after they've been fully vaccinated and boosted and have Omicron.
All right, let's keep going up in age. Now, I realize that it depends on everybody's medical history, but what about a healthy 70-year-old coming in, triple vaccinated, symptomatic COVID? What would you recommend?
Well, I would just try to get a sense of whether or not they wanted medications, if they were on other medications that could potentially interact with something like Paxlovid, because there are some drug-drug interactions that are important. I would mention that there are potential side effects with Paxlovid, gastrointestinal, metallic aftertaste, etc. Just kind of get a sense of what they might want. Some people want it for a peace of mind, and I think that's sometimes I think that's okay.
And lastly, so 70 is my age group, so I'm curious. I haven't tested positive yet.
And
so then we have our 80-year-old. Right? That's Dixon. He's a little bit older. What would you do there? Same thing, same idea, or would you immediately do something for an 80-year-old?
Well, so yeah, my dad is 80 or almost 80 and has really no underlying medical conditions. If he got COVID, knowing my dad, I would probably recommend riding it out, to be honest. He lives in Portugal, so it might be harder for him to access an antiviral. And that reminds me, a lot of people around the world don't have access to these antivirals, and they're doing fine, based on what I'm hearing from some of my colleagues. If it were an 80-year-old who came to our ER and they had medical conditions that were significant risk factors for complications, then I would recommend a monoclonal antibody like bebtelovimab, because it's one and done and there are essentially no side effects. That's my personal opinion, and we have, we have it in supply. Fortunately, we're privileged. If they weren't on any medications that could potentially interact with Paxlovid, and they didn't want to come in for an infusion, then I would recommend Paxlovid. Yeah. But I do want to see more randomized controlled trial data on Paxlovid in vaccinated patients. So the EPIC SR trial, I still haven't seen that data, which should have been made available a long time ago.
Yeah, you mentioned earlier, actually before we recorded, that you don't particularly like Paxlovid because you feel that many of the patients have the so-called rebound. Can you give us your thoughts on that?
I can't say enough about whether or not Paxlovid in and of itself increases the risk for rebound. So a lot of it is just anecdotal. And of course, we have to acknowledge that it's not Paxlovid rebound, it is COVID rebound. I completely agree. Okay. But from my experience, the people who have gotten any sort of COVID rebound have been the patients who have gotten Paxlovid. That doesn't say much, though. I mean, that might just be because people who took Paxlovid are maybe more inclined to pay close attention to their symptoms, or are more inclined to repeat their tests. So it's complicated. I wouldn't say that COVID rebound should be a deal breaker for someone who's considering Paxlovid, but it is something that I think we should pay attention to and gather more data on.
What happens to patients who experience a rebound? Do they typically recover?
Yeah, they do.
Okay, without any further intervention, right?
Right. I mean, sometimes they go through a second course, right? Like some of our political leaders. But for the most part, no, they just ride it out and they get better.
All right, so could we talk a little bit about long COVID? Is that something you have seen, and maybe you could define it for us if you have?
Yeah, great question. I think that defining long COVID is going to be very important, and the definitions have been a bit varied, right? I'm actually a sub-investigator here on the RECOVER study, which is a long COVID study that's NIH-sponsored. And I think it's very important that we get high-quality data over a long period of time and use comparisons and negative controls, right? And that, I think, is going to be just absolutely critical. A lot of the early data on long COVID were based on pretty low-quality evidence, right? And based on studies that didn't use comparison groups or controls. So it's so hard for me to know what the incidence of long COVID is and what the prevalence is. I don't think that the prevalence or incidence will be nearly as high in the Omicron era in terms of long COVID, caused by Omicron infection. And I think a lot of that has to do also with much higher levels of population immunity. Is it possible to get long COVID from Omicron in someone who's been fully vaccinated? Yes, I think it's possible. I think it'll be very unlikely and quite rare. But, long COVID, I think, is, hopefully we'll learn a lot about these syndromes that have been attributed to a number of other infectious diseases throughout history, right? So Lyme disease has been getting a lot of attention for leading to post-infection sequelae, all sorts of infectious diseases, brucellosis, et cetera. And there are a lot of people who do suffer from chronic fatigue syndrome or ME/CFS, and I think it's very important that we validate people's symptoms and try our best to understand the disease process and develop treatment. I think it's also important that we acknowledge our limitations in our understanding, and there's at this point, very little that I can say conclusively about what long COVID is and what works for it. But I do hope that the initial really high estimates of the prevalence of long COVID are reeled in a bit, because I'm personally not seeing long COVID. In 2021, I was getting a number of referrals to my office for long COVID, and I would refer them to the Stanford ME/CFS or PACS long COVID clinic. But I haven't gotten any of those referrals in the last several months. I'm not sure if that's indicative of anything or not.
I'm curious.
Go ahead, Rich. It's okay.
I'm curious about your perspective on the future, in particular, any variants coming down the pike. Do you keep an eye on this? Is there anything out there that causes you any sort of concern? What's your perspective?
Yeah, great question, Rich. There is some concern, and that's mainly because there are severely immunocompromised patients in the community who have, I think, clearly benefited from Evusheld, the long-acting monoclonal antibody that significantly helps prevent infection, right? And Evusheld is something that I have definitely tried to make available to my severely immunocompromised patients. And there is clear evidence that it's not going to work as well to neutralize certain subvariants. So BQ1 and BQ11, which make up about 30% now of, or almost 40% now, of variants circulating in the U.S. So there was more than 1,000-fold reduced neutralizing susceptibility. 500-fold. Reduced susceptibility to Evusheld, over 1,000-fold reduced susceptibility to bebtelovimab, which is the only monoclonal antibody that we've been using for treatment. So some of these subvariants, my concern is that we're not going to be able to treat them as well with the monoclonals. Okay. I'm not as concerned about resistance to Paxlovid, et cetera. But that is also a theoretical risk, and I think something that we need to be conscientious of when I think we're overusing Paxlovid just like we overuse antibiotics, and
So that
we
was
have
a
to be mindful of that.
That was a question I have, because it suddenly occurred to me that Paxlovid is addressing one function of the virus, and remdesivir is affecting another. If how much is resistance a problem, and should we be thinking about combination therapies, or would there be better pairs of them? Although at the moment those are the only two that I think have approval. But is there are people doing studies on resistance that you know of?
There have been studies, yeah. I can't recall some of the details at this point, but there have been studies. I think that it's been especially an issue in severely immunocompromised patients who get long courses of some of these treatments. So some individuals have gotten long courses of remdesivir and haven't been able to clear the virus because of their immune system, and they've gone on to develop resistance. On a population level, are there variants that have shown resistance to remdesivir or Paxlovid? Not to my knowledge. That's mainly an issue with the monoclonal antibodies. So I think that it's been extremely difficult to find effective antivirals, right? There's remdesivir and there's Paxlovid. I'm not convinced that molnupiravir is going to have much impact.
So Paxlovid is actually two different protease inhibitors. Do you know if there's cross-resistance between those, or is that essentially on its own right a combination therapy?
I don't know. I would think since it's combination therapy, there might be a lower or a higher threshold for resistance.
Okay.
I don't think ritonavir hits the SARS-CoV-2 protease, right? I think it's just
ritonavir is just the booster. Mm-hmm.
Yeah,
and we use that in HIV medications,
right?
In some HIV medications, so it just boosts the levels up. But Kathy, to get back to your question, I think that it's going to be really important to develop new monoclonal antibodies that keep up with the new variants as they evolve, because they're inevitably going to be new variants that are resistant to our monoclonals and even to some of the other antivirals.
And in the email that you sent me when I first contacted you, you had a couple of things I wanted to touch on. And one of them was this conflation of infection versus disease and, what vaccines do. Why are we in this situation?
Why are we in this situation?
We're conflating the two, right?
Yeah. It's a good question. I think that,
my theory is it's because not enough people listen to TWiV, but what is yours?
Boy, I've got a lot of theories about it. I've always just been, for the last 10 years, a clinician. I haven't focused a lot on science communication, but this pandemic has really opened my eyes to the importance of careful science communication. And I think that social media has played a significant role in sending very mixed and confusing and misleading messages.
Yeah.
I think Twitter in particular, as David Quammen mentioned, there are reckless public commentators, right? Some of whom have huge Twitter platforms, right? I mean, over 100,000 followers, and some of whom now own the platform. Right. But the voice of clinicians who are seeing COVID, the voice of infectious diseases physicians like myself, have been, overwhelmed, or the loudest voices have been people who have not necessarily been seeing COVID patients on a daily basis like we have, right? So, but a lot of the public don't know who the experts really are, and so I think that a lot of pundits and commentators have made that conflation between infection and disease. And I think it's been very important to point out that there's a huge difference, and that we have to acknowledge that the expectation should be that SARS-CoV-2 will continue to cause infections, probably for the rest of our lives on a periodic basis, right? Maybe every couple of years. But what's most important is that protection against severe disease, COVID-19, will likely remain robust for a long period of time thanks to cellular immunity. And I think that the other reason why there's been that conflation between infection and disease is because of the total fixation when it comes to vaccine communication, total fixation on antibody titers, right? And preventing infection, without putting it into the context of, the vaccines provide great cross protection against different variants, and in particular provide long-lasting protection against severe disease. So, and I also have to say that the booster discussion has made this even more confusing, right? And this is why I took issue last year. I wrote the BMJ editorial with Muge Chivik and Aaron Richterman on the evidence of waning is overestimated, right? And that's for me, what drove that for me was that the protection against infection, that's going to wane, right? Studies have shown that after a third dose, protection wanes after maybe 4 months, and after a fourth dose, it wanes even faster after 4 weeks. And so I don't want people to get discouraged when they get an infection 2 weeks after they got their bivalent booster. I don't want that to be considered a breakthrough infection. And that shouldn't be considered a failure, which is a point that Dr. Offit has made multiple times, and I completely agree. So the messaging around infection and disease and the role of vaccines, that I think has led to a lot of this sort of confusion. So that was a long-winded answer.
There's to put a little perspective on this as well, for somebody who works in science communication, there's a long tradition of a particular message in vaccines and in explaining vaccines to the public in general, where we talk about the vaccine isn't just for you, it also protects those you love from getting infected. And this is used for flu vaccine, for a bunch of different vaccines. You're protecting other people who you might infect. And for some vaccines, that's probably a reasonable message. I mean, some flu years that you may actually have enough antibody-mediated immunity to be protective of other people and to prevent infection with the flu vaccine. But I think that was just borrowed as a whole piece for COVID-19 communication, like so many things from flu. Now we got to get everybody vaccinated. We're going to use the same supply chains. We're going to use the same message, which is you're also protecting everybody who you come in contact with. In order to do that, you have to assume that the vaccine is preventing
And I think that did apply to the COVID vaccines more so in 2020, right? There was better effectiveness in terms of protection against infection, and it lasted longer. And that was before these more antibody-evasive variants, right? So in 2020, vaccines significantly helped prevent infection, and they helped prevent transmission. In 2022, that's much less of the case. And but again, the silver lining is that our protection against severe disease is robust and durable, and Omicron, I think, is less worrisome.
I'll link to a tweet that you sent me where you point out that statements made by two people said these tweets are wrong. Pfizer and Moderna vaccines were shown to be over 90% effective at preventing COVID-19 symptomatic disease, not infection. might seem trivial, but using infection and disease interchangeably like this is misleading. Does anyone call you for comments ever?
Yeah, sometimes, not that much. And I was just thinking, it's funny. I was interviewed by, I won't say who, but it was a national public radio. And I had emphasized what I had been seeing, which is what I discussed earlier in the show, and what my colleagues have been seeing and how dramatically better things are. And I was really just pleading to get that information across, because it is missing, I think, from public discourse. And it wasn't included. And I don't know why. I think that, I've heard that these sort of takes are controversial. We're sometimes accused of being minimizers. We're attacked on Twitter. And I mean, COVID has become so politically fraught. And the way in which COVID was handled by our president in 2020 made things a lot harder for us even now, I think, because, if you disagreed with school closures, then you get written off as a Trumper, say. And I think that also applies sometimes to someone like me saying that the death rates are overestimated or they're not accurate. But yeah, so it's been challenging. But I do think that from what I'm seeing and from what a lot of my colleagues around the world are seeing, the metrics that we're looking at don't work anymore. Well, they're not accurate. And I think that we need to recalibrate our metrics and our goals.
One of the things that I hear a lot from people is that they're scared to death, even though they're triple, quadruple vaccinated, they're scared to death of long COVID, right? And I don't know what to tell them about that. Do you have any insight?
I get that a lot too. I just try to provide reassurance that in this current Omicron era and this post-vaccine era, it's less of a concern. There are a lot of evidence that recovering from a critical illness leads to long-term sequelae and disability, right? So there's a post-intensive care unit syndrome, right? And I think that, the data that I've seen have made it clear that earlier in the pandemic, people who had more severe disease were at higher risk for long COVID. And so I think that the risk should be expected to be lower at this point, since there's far less risk for critically ill COVID.
This really emphasizes what you were saying earlier about how it would be good to have good numbers.
Yeah.
For a good definition and good numbers for long COVID, because my first reaction to Vincent's question is, well, what's the risk of long COVID? Because when you start talking about this kind of stuff, my first thought is, well, do you drive on the freeway? And because I compare everything to that, because driving on the freeway and taking that risk is perfectly acceptable. All right. And so if something has less risk than that, then I'm not going to worry about it. Okay. But I don't know what the risk of long COVID is, right?
Yeah. Well, and we probably won't know for a while.
Yeah.
Right. We won't know in real time what the risk is, and the risk will be constantly changing. So the risk in 2020, I think, was dramatically higher than the risk is now. So, I basically try to just reassure those people. I also think that we need to change how we define hospitalizations and how we define deaths. Deaths due to COVID should be based on chart review, I think. Some places in the country are doing that. I believe LA is doing that. And when it comes to COVID hospitalizations because of COVID, where the decision to admit the patient was because of COVID, that needs to be more clearly defined. So some states, like in Massachusetts, are using the use of dexamethasone as a sort of proxy for for COVID hospitalization, but a lot of states aren't. And so, when we continue to do screenings on every patient, like I said, who's admitted, regardless of what they're admitted for. So as long as we continue to do that and don't account for some of the real reasons why patients are admitted, the hospitalization rates are going to be dramatically overestimated.
So you said that the metrics are no longer, I don't know quite how to say this, but maybe no longer totally appropriate or relevant. So if you were in charge of creating the dashboards, what would be there? What would you use as metrics to sort of monitor the situation?
Yeah, great question. I mean, there's no gold standard, obviously. I would probably use the system in Massachusetts, using dexamethasone, using the use of supplemental oxygen. Another factor is we're relying on PCRs for these COVID hospitalizations, which might reflect an infection from 3 months ago. What if we used a rapid test instead, or an antigen test? Or what if we use the cycle threshold value, right? What if we incorporated that data? Because, if I do get called to see a patient for COVID who comes into the hospital, I have to call the lab and ask them to tell me what the cycle threshold is. They have to look it up and tell me. Oftentimes they'll say it's 40. And I will see that the patient has maybe a clear-cut bacterial pneumonia. And maybe they have difficulty protecting their airway, difficulty swallowing, and they have recurrent aspiration pneumonia, and they're here again with aspiration pneumonia and COVID with a CT value of 40. And so that I don't think should be considered a COVID hospitalization, because the COVID probably had nothing to do with even the aspiration pneumonia.
But that's how we treat it now, right? We treat it as a COVID admission, right?
Yeah, exactly. And then we get asked to decide whether or not the patient needs remdesivir and dexamethasone, and oftentimes they get dexamethasone. So even the use of dexamethasone won't be a perfect proxy, because the diagnosis of true COVID these days, in my opinion, is a clinical diagnosis, as it is with a lot of diseases, right? And that depends on good clinical judgment, which varies. So if someone comes in and they have a positive COVID test and they are coughing, and maybe, sometimes I'll see patients who are very briefly hypoxic, meaning their oxygen level is low for just a few minutes during a coughing spell. And then they'll get admitted for hypoxia due to COVID. But after the coughing spell, they're perfectly fine. So it's so hard to clearly define a clear-cut COVID pneumonia. I think the X-ray findings should be incorporated in those definitions. So, but I wouldn't be very good at making those policies, because I'm too obsessed with nuance and proper context.
Yeah, so a problem in making the policies is somewhere you got to draw a line, right?
Yeah,
and
that's why I stick to seeing
there
patients.
really are no lines.
Right.
So it's not just a PCR value, it is clinical judgment, which is not easy, right?
Right.
Right. And with clinical judgment, there's going to be a lot of heterogeneity, and quality is going to vary, obviously, and you can't chart that necessarily. You can't bill for that, So much of our definitions are based on billing codes and test results. Not
circles back around to your initial thing about how you like the stories. Stories, right. Listening to the stories and
Yes.
and sort of evaluating them, that's clinical judgment, right?
Yeah.
Exactly. Yeah.
Well, and to change a policy, you also have to convince the person who implemented it, who quite likely still works there, that the policy needs to change, and that could be the higher
that's a
hurdle.
good point. And I think that there are so many different forces at play, right, that make it very difficult for the policymakers to make changes. And there's a lot of inertia. So I think it's going to be a while before we have more precise metrics.
Just my last question is: are you seeing a rise in other respiratory infections here? We're entering November.
I have not seen a rise. There's certainly been lots of reports of an increase in RSV. There's a little bit of an uptake of flu in the area. I haven't seen too many in the hospital. But I will say that I've seen a fairly significant increase in various complications from underlying medical conditions as a result of inadequate medical attention. So September of this year was the busiest month that I had had since January of 2021, by far. And I didn't have a single COVID patient that I was asked to see, but the hospitals have been completely full, and it's been extremely busy. So I've seen more newly diagnosed HIV in patients who present with end-stage AIDS. I've seen more tuberculosis than I typically see. I've seen a lot of complications from underlying peripheral vascular disease and diabetes. And I just can't help but think that some of that is due to the pandemic.
People not getting medical care, right?
Yeah.
Yeah, I was going to say, it sounds a little like
Delayed care.
neglected ordinary infectious diseases.
Yeah, and we've also seen a big rise in complications from mental health conditions. We've seen more injection drug use related infections. We've seen a lot of suicides, et cetera. So the correlation doesn't equal causation, but it has been disturbing.
I wanted to just push a little harder on the RSV because probably everybody on the show has had friends or family say, "What about this new RSV virus?" And we get to gently say, "Well, to us, it's not new." But there was this story in the New York Times about peds ICUs being busy and adult ID docs being called in to now be peds ID docs, although they don't have the expertise and training. So you haven't seen so much of that in your hospitals.
Right, and I should definitely clarify and emphasize that I don't see pediatric patients. So I don't see kids under, say, 16 typically. But yeah, no, there's clearly been a dramatic rise in RSV in the community. It's not something I've been seeing yet, but I do see every year. I see a fair amount of RSV in adults that leads to respiratory failure, and sometimes it can be quite serious, especially in immunocompromised patients.
But you haven't seen an increase in adult RSV in particular?
Not yet, but I anticipate seeing it. Yeah. And I anticipate seeing more flu.
Yeah, flu, I suppose. Even in California, there's a flu season, right?
Right. Yeah. Well, there wasn't for 2 years. I mean.
Yeah, of course.
It was phenomenal.
Nobody had a flu season for 2 years.
Anything else, folks?
I'm good.
All right, Jake Scott, Stanford University. Pleasure, Jake. It's been fun. I really learned a lot. I appreciate you coming. Thank you.
Yeah, thanks. This
Thank
is great.
you.
This is really good.
Appreciate it.
Nice to meet you.
Thank you. This
Likewise.
was great.
Thank you.
Okay, good to hear from a different clinician, right, on the other
Yeah.
side of the country.
Yeah, very good.
Yeah.
So that's from my fundraiser, Jeff. Thank you, Jeff, for connecting us. Appreciate it. Yeah, very good.
Very good.
He was good.
It's really
great perspective.
nice to have the boots on the ground perspective.
Yeah. That's who they should talk to, the CNN, and not cut out things that they don't want to hear, right? It's crazy.
Also, nice to hear about somebody who started out and didn't quite know what they wanted to do and did a variety of interesting other things. And then
I think that's great because...
Well, it's funny. His background is very, very similar to my wife's. She majored in comparative literature and actually worked in the publishing industry for a couple of years as a book editor. And then decided, I really do want to be a doctor. And she had to do the post-bac pre-med exactly like, same type of thing.
You can be undecided. You don't have to come out of college and know exactly what you want to do, right? It's just, experimenting. Go to Japan, it's great.
Yeah. Yeah, and you certainly don't have to know what you're going to do when you're going into college. Which
Well, there's a lot of pressure to do it, right?
Yeah. What are you going to major in?
I should
you haven't
shout out
graduated high
to
school yet.
Rose, one of our TWiV listeners, who was in town, and I had lunch with her and took a walk last week. And she had an engineering undergraduate degree. She had I don't know if it's an architecture degree or she was never she was into architecture for a while. Then she was a nurse. Now she's a health reporter.
That's good.
Cool.
Mm-hmm.
Yeah.
She gets it right, hopefully.
And as long as I'm shouting out, I had lunch with Neva last week, too.
Yeah,
Hey,
good.
Neva.
She said in one of these emails which time,
Okay.
yeah.
Yeah.
All right, let's do some email. I want to read this postcard, which arrived at the incubator a couple of weeks ago. This is a postcard from Stockholm. This is the city hall where they have the Nobel dinner. And this is from Jan, who wrote, Vincent and all TWiX hosts, I want to thank you from the bottom of my heart for all your efforts to bring science to the people. You make it accessible and understandable while keeping everything in perspective. I count on you for insights and context I cannot get any other way. You bring us great joy. You bring me great joy and inspiration with absolute appreciation, Jan T. So thank you so much, Jan, for the cool. This is room packed with people. And there's 18 inches per person. I think that's what Erling Norby told me. Thank you, Jan. We appreciate it. All right, let's go back. And Kathy, could you take that first one?
Sure. Bob writes, Dear Twivers, 1. Car Talk still comes out with reruns twice per week as a podcast from NPR. These are shortened versions and go way back. This is the only podcast I put in my playlist above TWiV. I don't cry much, but I shed a few tears when they announced that Tommy had passed. So I kind of agree there. 2, I also listened to the Mindscape podcast by, wait for it, Sean M. Carroll, who once had Sean B. Carroll on his show. It covers more than just physics, if you are wondering. So, yeah, thanks, Bob. That really helps. I'm happy to hear that. Anyway, Bob continues, thanks for such an informative podcast. Since I'm not a virologist, doctor, chemist, etc., it is safe to say I always learn something. Bob. And he says currently it's 61F this morning, so that means it was 16C.
We were really confused about Sean Carroll, weren't we?
Yes.
Yeah. We kept going on and on, trying to figure out who was who. Alan, could you take the next one?
Sure. This is a letter from Frank, who sends a link to the coming attack on science. This is a House GOP letter to Rochelle Walensky.
Basically complaining that research isn't safe and we need to, in light of our concerns, please make arrangements to discuss how these concerns could be addressed. You know, like, look, they don't like that we're going out sampling wildlife. They think it's too dangerous. And so that's why Frank calls this, the coming attack on science. And as you know, there has been a GOP document, a completely absurd, baseless GOP document about the origins of SARS-CoV-2. Which we may comment on next time. And some rebuttals, which I think, Kathy, you sent a nice rebuttal. And there's also a Forbes article, which is very good, at saying basically this is all politics. It's not a science document, which is very good.
Yeah.
So by Frank, it's...
it's not sampling the wildlife is how you end up with a pandemic.
I don't know how we got here.
When you mentioned Frank, that's Frank Pallone Jr., the New Jersey... representative who's a chair of this committee, I guess, and is the main author, signing author of the letter. I haven't gotten to the bottom yet.
Frank is the guy who sent
I understand
Frank is
now.
the letter writer.
I'm looking at the letter, and no, Frank, whose name is on the stationery, did not sign the letter. Okay.
No.
Rich, can you take the next one?
Arlo writes, hello, my name is Arlo. I have found my love for viruses when I was in 6th grade, about 5 years ago. Since then, I studied as much as I could, but this year I reached a cap on what I could study. I have 3 years until university, so I wanted to ask, do you have any recommendations on books or programs for a high schooler to do? Thanks for reading this. So my immediate reaction to this was phage, and in particular, the Howard Hughes program that you can find at cphages.org, which is basically a phage discovery thing that is mostly, I think, college students, but high school students, it happens at the high school level as well. And I wrote to one of my ex-students who is a professor at James Madison University, who, after my lab went and actually did a postdoc with the Pitt group.
Oh, yes. What's his name?
Frank Graham, not Frank Graham. Is it?
No.
Graham Hatfull.
Graham Hatfull.
Yes, thank you.
Yeah.
And
Graham
who's the guy?
Hatfull.
Roger
Right.
Hendricks, who died, right?
He died, yeah.
And there was another one. At any rate, so he did a postdoc with them, got a job at James Madison University, and has run this Howard Hughes program for a while. And he says, I asked him what he would recommend. He says, hi, Rich, yes, cphages.org is a great place to send him if he's interested in phage therapy. The Perfect Predator by Stephanie Strati tells her and her husband's personal story on the topic. That's the same one that we went through at Texas A&M.
It is.
Right? Mm-hmm. That's that story.
Yep.
I think so.
For
yes.
phage genomes, you could refer him to phagesdb, that's PHAGESDB.org, or even Framerator, Framerator, PHRAMERATOR.org. These would give him computational things to think about and do, so wouldn't require a laboratory, etc. And of course, there's always the wash dishes option, but these are good, accessible options. And that's from Steve Gerson.
So, Arlo, if you wanted to listen to that TWiV from Texas A&M, it's TWiV 502. It's called Texas Road Phage. So we talked to several
who
phage
made that
virologists.
title?
Yeah. And it was there that we got our pillows.
Yep.
Yeah.
Pillow right behind
Yes.
Yeah, and there's one behind Alan.
me. Alan has a pillow.
Mine's not in view, but it's right over my left shoulder.
Mine's on the spot the cat is supposed to go to instead of coming on the desk. But
Right.
Justin writes, hi, Vincent and the rest of the TWiV gang. I wanted to start out by thanking all of you for producing such wonderful podcasts and sharing your insight with the world. Microbe TV podcasts are some of the few I get truly excited for when they pop up in my feed. I'm a non-traditional undergrad student working towards a degree in wildlife biology after taking a few years away from school, and though I don't always understand all the technical virology medical terms, I'm always fascinated to learn from these shows. I am particularly fond of the episodes tying in ecology and wildlife science into the field of virology. With the circumstances of COVID-19 and learning more about zoonotic diseases in general from your podcast and books like Kwaman's Spillover, I'm starting to consider doing my graduate degree somewhere in the interface of health and wildlife ecology. Still not entirely sure what direction I want to go, but are there any general subjects that you might recommend taking a course or two in that could prepare a wildlife-focused biology major for grad school in a more health-focused field? Additionally, I know this is asking a lot, but do you have any particular recommendations for agencies, labs, etc., to look into for internships, jobs for someone with my background? I truly appreciate your time and expertise. Wish you all the best and good health, Justin.
So working toward a degree
The
in
interface of
wildlife
human
biology.
health, right?
Yeah, I mean, take microbiology, virology, if whatever of those courses you have access to at your school. certainly. If you're already taking the wildlife biology,
Ecology, right?
Pretty well
Probably is
covered.
taking ecology, but that's for sure.
Yeah.
If you have an emerging infections course, you should take that. I don't know how common that is at that level,
And talk to some of your professors. They might know of a course that might just be perfect.
Yeah.
There
Yeah.
might be some kind of disease ecology course or something that could be useful.
Yeah, Dixon would have thoughts on this.
he would. I told him not to
Yeah.
come today. Recommendations for agencies, labs, etc. I knew the first.
Your local wildlife agencies, sometimes or state level. Sometimes there's there are projects going
Yeah.
on in infectious disease at that level.
And we don't know.
Is Justin in the U.S.?
We don't know where he is or whether he wants to move. But
But again, talking to your professors in your
Yeah.
courses, they might know somebody or know somebody
Yes.
who knows somebody. We're kind of coming up blank here at the moment, but for specific people
Yeah.
in your area or that you could network to, they might be able to help you.
I mean, if you're at Emory and you're in Atlanta, I have a rather obvious suggestion that maybe you ought to, talk to your professors
Yeah.
about getting an in at the CDC. But outside of that, I don't have.
if you're in Colorado, go work with Tony Schounts.
Yeah.
Yeah.
Could be.
Right.
It depends where you are, right? Or so. All right, back to Kathy.
Okay, this is Craig.
Yep.
Craig writes, a rabies infection moves toward the brain slowly enough before causing disease and death that a vaccine administered after exposure has time to work. But then why do you need the vaccine? Generally, a vaccine is administered to give your adaptive immune system time to develop a response before seeing the actual pathogen, to do the slow work of learning in advance, so it can respond fast enough when the real pathogen appears. If the pathogen is this slow, why doesn't the immune system just handle it without a vaccine? Does the rabies virus have countermeasures which hinder the immune system from developing an adaptive response, such that the vaccine is more effective at eliciting protection? Thanks, Craig. That's a really good question.
A really good question.
Yeah.
That is excellent.
So, Vincent's put a comment in here. Do you want to just take it, Vincent?
Yeah, I just looked it up, and there's an article. Said important. This is a quote from the abstract. A number of studies in recent years have indicated that rabies virus specifically suppresses host immunity through diverse mechanisms, and this is a key process in pathogenicity. So that's why you can't just let rabies go wild. It'll kill you.
And rabies only has to delay the immune system long
Yeah.
enough to get
Yeah.
into your
Yeah,
nervous
that's what I
system
was
to
wondering,
kill
if
you.
the nervous system is relatively or completely immune privileged.
It's
Yeah.
relatively privileged. Yeah.
Alan, I think you're next.
Okay. Philip writes, we went from Wuhan to Alpha, then Beta, Gamma, and Delta within a year and a half. For the last 10 months, it has been Omicron in its various forms. Does this mean we are seeing smaller incremental changes without major changes that would move us to the next letter in the Greek alphabet? How would a virologist explain this? Well, the way I would explain it is that this is a deliberate effort to deprive me of my pie puns. I was looking forward to pie, and I think I'm never getting pie. But more seriously, yes, the argument is that the Omicron substrains are less dramatically changed than, say, Omicron from Delta. And so you have Omicron, BA1, Omicron, yada, yada, yada. And I guess if we get a big enough change in the virus, then maybe I'll eventually get my pie. But by then, nobody will care.
I don't know why it isn't making big changes anymore, right? I'm not sure.
Well, Omicron was huge,
It was huge.
So
Yeah.
I have to wonder how frequently that can happen. Because that to me, that was so huge that it's like a pretty rare event.
I think Omicron hit the Powerball. So it managed to hit on the set of mechanisms it needed to spread efficiently, really efficiently in humans. And so it's all Omicron now, and then that strain would need to have some selective pressure that's going to drive it in a completely different direction. But I don't see that
it's
happening.
continuing to change.
It's in
changes
every
slightly.
country.
It evades immunity, as you heard from Jake. But I don't know. We should really know where it came from. That's part of the problem. We don't know where it came from, and that might give us some hint, right? But we don't know where it came from. It's a good question. Good question, Rich.
Brian writes, Dear Twivers, I listened with great interest to your interview with Dr. Offit. Excellent as usual. That said, I found it baffling the comments about Canada relaxing its vaccination requirements for entry. I've heard this on a number of podcasts about how bizarre it is that Canada has COVID vaccination requirements for entry. This was apparently particularly offensive for sports fans because their favorite steroid abuser wasn't able to enter without getting a vaccination. I've attached an article which seems to show the U.S. has exactly the same requirements. Keep up the good work. I'm looking at this article.
This is a 2019.
It's just
updated August 2022.
If you
updated
are
August 24th,
non-U.S.
2022,
citizen,
yes.
You must show proof of vaccination before you can come in the country.
I'll be darned.
That's interesting. I don't know what the Canada regulation is. Is it everybody?
Is that still
Canada?
in place?
The people who recently came here from Brazil were supposed to show it when they were still in Brazil, and one of them said, "Don't you want to see my vaccine card?" So it might not have been all that rigorous, but whether I should ask whether they also got asked again once they got to the U.S.
For travelers entering Canada by air after October 1st, 2022, proof of vaccination is not required.
So it just changed.
Nothing's required.
What if you're entering Canada by land?
Air, land, or marine mode. It's all three. So they are more lax than we are.
And this is, in the CDC thing, this is a weird distinction, to me anyway. Non-U.S. citizen, non-U.S. immigrants must show proof of vaccination. So the virus can discriminate whether or not I'm a citizen?
It's weird. It's very weird. That doesn't make any sense.
Yeah.
But,
no.
All right. Thank you, Brian, for that little bit of entertainment.
All right.
Oh, God.
Kim writes, so Kim sends a interesting little clip. She must have taken it from her phone, but it's all about a SARS, an SARS. SARS are a sign of heat energy leaking into the upper atmosphere from Earth's ring current system, a donut-shaped circuit of plasma containing millions of amps around our planet. And there's a picture of it. SARS are among the reddest things in the sky with a monochromatic glow at 6,300 angstroms that comes from atomic oxygen in the upper atmosphere. The human eye is relatively insensitive to light at this wavelength, but cameras can record the color easily. So I think that Kim sent this because, it's another SARS, but this one is pretty.
Actually,
right?
I seem to recall an episode way back where we discussed some misunderstanding of this that was misused by somebody in some sort of conspiracy thing about SARS-CoV-2 and the atmosphere. I forget what the details were, but this is familiar to me in some sort of context like that.
What is
what does it stand for, right?
Yeah, that's what I'm trying to figure out, and it's
something
impossible.
atmospheric.
You got to go to the 452nd page.
It's synthetic aperture radar. No?
No. It's also not search and rescue. These are a natural phenomenon. Synthetic aperture radar is something you would use to detect things. These SARS are a natural phenomenon. Heat energy leaking into the upper atmosphere.
All right. Well,
I don't know what it stands for in this context.
There's more here on this email.
Yeah, I'm going to read the rest.
Okay.
Yes.
This is from your old friend Kim Without Borders, Dentist to the World. That's great. Most recently in Samoa and Tonga. 2 days later, far northwest Alaska, to pay for my volunteer work, where the remnants of a typhoon battered the shores. And 2 days after that, Austria, where I was on a bike trip, cut short when I was hit by a car while I on my bike torquing my knee. An eventful couple of months. I was happy to listen to your podcasts while nursing my bruised knee, etc. Thank you. And I'll attach a video report of the weather for you.
I think that's the tail end of
Oh,
the
this is a
typhoon or
video of
something
some
like that.
typhoon. Yeah, yes. Oh, so you got Sarah, Alan?
I got it.
know
I'll
some-
tell you how
yeah,
I Googled
Kathy just pasted
it.
it
Red SAR 6300 angstrom.
Nice.
Ah, that's what I needed.
And it
Okay.
And
stands
so what'd you
for
get?
Stable Auroral Red Arc Emission, observed over North America from space by the Dynamics Explorer 1 satellite. I just put in the top hit that I got, but yeah. Stable
Yeah.
Auroral Red. Yeah.
Red. So Aurora, that's like Aurora Borealis, the northern lights, but this is a stable red emission coming out of the
I'm just going to
aurora.
read one short one that I just pasted in from the end. This is from Susan, who writes, that was a funny, dry joke about Emma Thompson. I was falling asleep and got all confused. So when we mentioned Emma, Brienne mentioned the movie name that she was in. What was
Right.
it?
Or she said, yeah, not Pride and Prejudice.
Pride and
or-
Prejudice.
Yeah.
So Susan was falling asleep and got confused. That's what happens. Thank you. That's
What?
great.
Falling asleep listening to TWiV? Wait a minute.
How can that be?
Yeah, it can happen. All right, let's do some picks of the week. And those of you who would, today was going to be, wasn't today Dixon's GOAT of jazz, right? Yeah, so
Yeah,
Dixon's not
probably.
here, but hopefully
yeah.
he'll be in next week and you can hear his GOAT. So, Kathy, what do you have for us?
Well, I was thinking of this when I thought Dixon was going to be on. So I picked 10 moments for Jazz at Lincoln Center Orchestra residency. So they were here at the University of Michigan for a week in mid-October, and there are 10 moments. They were at a football game. They did a big concert that I was part of, and that's item 7. So it's just really cool, and it's another aspect of jazz that we haven't heard Dixon talk about yet. So I will definitely send him this and tell him he should check out this list. And the other thing is that I have now, with all these other intervening books that I needed to listen to, I've been listening to The Kissing Bug by Daisy Hernandez. That was Alan's pick from TWiV 931. And so I can join on to Alan's recommendation. And speaking of Dixon, he gets a call out in the book itself. So if you listen far enough into the book, you'll hear
Yes.
about Dixon. But The Kissing Bug is just, it's really, really well done. I highly recommend it. So thanks, Alan, for suggesting that.
Good.
Yeah.
I'm glad you
Dixon
enjoyed it.
was sitting at, so Daniel Griffin purchased a booth at ASTMH, right? So he had a really big booth with all kinds of cool graphics and handing out books and pamphlets and stickers like this one, Parasites Without Border, you can put on your computer. And he was sitting, so there were 2 chairs and bookshelves with all kinds of parasite curios. I don't know where he got all this stuff. He probably just told someone to buy it. But and Dixon was sitting there and people were just, they would pass and look, Dixon, and come over and talk to him. Say, there's this continuous flow of people because he hasn't been around at this meeting for a while. And of course, this was his meeting he used to go to a lot. So that was pretty cool to see that. Yeah.
Oh, that's great.
Rich, what do you have for us?
I have. Some time ago after we returned from our trip to Africa, I picked Wilderness Safaris tour group as my pick of the week. And this is the Wilderness Safaris photographic competition results for 2022. And so they have a photography competition where people, I don't know if this necessarily people on their tours, but people obviously in Africa submit photographs to them, and they have a judging panel that judges them, and it's just an amazing bunch of photographs of Africa. And I just linked to the results here, but if you poke around, you can find a gallery that's got hundreds of pictures from the past, and these are just really nice pictures.
This one with the monkey and the finger is just...
Yeah, isn't that amazing?
It looks like the monkey had a haircut. Look at that. Holy cow.
And there's the...
It's not a monkey.
The little guy is a gorilla.
These are mountain
And there's
gorillas.
a lion and what looks to be a warthog. You can't really tell. I can tell from the tail, because the warthogs, when they run around, their tails stick straight up in the air. Okay? And Porter's comment was that they look like remote control buggies with the little antennas sticking up. That's good.
This little guy's going to get eaten, I guess.
I think so. I think
Nature's tough.
Nature is tough. And I like the pangolin down the bottom. Somebody
Pangolin's
holding
great.
onto a pangolin. Yeah. At any rate, good pictures.
I don't know if you
nice.
read Breathless. There's a couple of pages on pangolins.
Yeah.
They're very sad. They get poached more than anything else, you know. Too bad. Alan, what do you have for us?
My pick of the week is an organization that last week invited me to give a keynote presentation at their meeting. This is the Massachusetts Science Education Leadership Association. For those of you who are MASILA members who are listening, just a shout out. And Liz Baker, who was responsible for inviting me. This was just a wonderful experience. They had their meeting out in Marlborough, Massachusetts. They put me up for the night out there. It's about an hour and a half drive. And it was just great to hang out and interact with these science teachers and people who run science programs at the K through 12 level, who are just at the front lines of one of the most important things that I can think for anybody to be doing these days. Just great people. And I also wanted to link to the talk that I gave to the group. I went ahead and posted that on my blog, The Turbid Plaque. I am once again posting things on The Turbid Plaque and also on my personal blog on Alan Dove, since I deactivated my Twitter account. So if you want to keep track of me, you can follow me on the blogs. But if you want to just see this talk that I gave, if you feel like having a long read on the state of the media industry and misinformation and how we got to where we are.
All right, good.
This is my take on it.
Before I do my pick, I just want to show you, Daniel had some brochures made up. This one is Microbe TV, and
Nice.
it's a trifold. It's got pictures of the incubator. It's got all you guys' names here listed, our experts. Then it has
Awesome.
It has all the shows here listed, all of our podcasts. It's really well done. Very nice.
Cool.
So he was handing these out, and I have a bunch left, which when people visit, I'll give them to them. All right.
I'm not an expert. I'm just a curious guy who speaks DNA.
All right. I'll change your name to non-X. We have welcomed such notable guests as Dr. Anthony Fauci, Dr. Paul Offit, Dr. Marion Koopmans, and Andy Slavitt. Oy. Well, he's notable, I guess.
Oh, he is notable.
Okay, very good job. And my pick is the last in my 5-part series on detective fiction, which I could not complete without Andrea Camilleri and his protagonist, Inspector Montalbano. I don't know if any of you guys have ever read these, but they are just amazing. They're written originally in Italian and translated. But they are about a policeman, an inspector in Sicily, and there's a bunch of books. He died very recently, so they're not going to be any more. And the link I'm going to give shows them in order. So the very first book is called The Shape of Water, and so it's basically this guy Montalbano. He loves Salvo Montalbano. and he has a couple of policemen who work with him and a variety of other people. It's all very funny, and Montalbano just loves to eat. And he always talks about the food. He lives alone, and he has a housekeeper who cooks for him. And when he gets home from work, he opens the oven and looks at what she's made, and he describes it. They're all described in the Italian and often in the Sicilian dialect, which is pretty cool. And it's very funny when he sits down with someone to eat. He doesn't want any talking. No talking during eating. Just wait till we're done. So all kinds of stuff about food, like you don't put cheese on linguine with clams, for example. You never put cheese on a seafood pasta dish, and many, many other things. He's really into it. And he'll go to lunch and his favorite place. What do you got today? And he eats a lot of stuff, and it's really good. I really enjoy it. And then the detective part is really good too. So it's Shape of Water, the Terracotta Dog, the Snack Thief, the Voice of the Violin, etc. And
The Shape of Water was also a Guillermo del Toro.
Yeah, some of them are
I hope so.
Completely unrelated to this.
Yeah.
Yeah, I was a little confused when I saw this.
Vincent, do you have a ranking for these picks? Is this number one?
I don't think I could rank them. They all are different, right? I have a special place in my heart for this one because they're, in Italy. But I mean, I had the Martin Beck is great. I can't remember even what are the other ones I picked. So no, I like them all, and you should try them. And many people have been writing in suggesting others too, so that's great.
Have any of you guys watched the new Masterpiece series Magpie Murders on PBS?
Not yet.
Oh man,
No.
it's good.
Okay.
You're gonna make it a pick?
No, I just did.
All right. So we have two
That's
listener
good.
picks. We have Frank who sends a link to. Let me see. It's a paper in ecological economics, which I've never looked at, called "The Economics for the Future Beyond the Superorganism" by Nina Hagens. Nate Hagens. Sorry, Nina Hagens is a wonderful singer. I don't know if you ever heard of Nina Hagens. Oh, she's so good. She is an operatic singer who sings punk rock. Oh, she's so good. Nate Hagens tells a great story of how we have become an autonomous superorganism. Huh. This paper tends a cohesive narrative on how human evolved behavior, money, energy, economy, and the environment fit together. Wow.
Man, this is creepy.
Looks like it's open access. Yeah, I can get it here.
Mm-hmm.
Wow. All right, thanks, Frank, for that. And then we have a pick from Debbie. Hello from a loyal listener. Thanks for keeping on with your commitment to science education. I'm enjoying learning. I thought you might enjoy this podcast from our national radio program, the CBC. For those more inclined to read than to listen, the webpage has lots of information and photos. Most of the podcast is in the voice of a woman who describes her experience of having polio twice in childhood, her career as a psychiatric nurse, and her experience of post-polio syndrome later in life. Oh, interesting.
Yeah.
As routine vaccination rates fall, polio survivor hopes her story reverses urgent trend. So the only way she would get polio twice would be if she got two different serotypes, I think. So she got first infected when she was 8 years old in Gladstone near Winnipeg. The only effect was no longer being able to run quickly. Then she was infected during the 1953 by another strain. They say it, actually. Good. Huh.
Yeah.
And she couldn't walk. So that's interesting. And she got post-polio years later. Thank you for that. That's cool. Thank you, Debbie. All right, that's it for TWiV 952. You can find the show notes at microbe.tv/TWiV. Send your questions, comments, pics. Please send them in. TWiV at microbe.tv. If you enjoy what we do, we're going to keep doing it. Microbe.tv/contribute. We'd love your support. Kathy Spindler's at the University of Michigan in Ann Arbor. Thanks, Kathy.
Thanks. This is a lot of fun.
Alan Dove's at alandove.com. Alan Dove on Twitter. Did you close your Twitter account? All right,
No,
I got to take
I'm
that
not on
out
Twitter
of the
anymore. So I'm at alandove.com, and I am also putting posts on turbidblack.com, although I'll cross-link
right
from
here.
the Alan
No
Dove site.
more Twitter. A lot of people are leaving
Yep.
Twitter.
In fact, I just put a post on Turbid Plaque for 5 things to do after you quit Twitter. If anybody
Rich
wants to-
Condit is an emeritus professor,
on that.
University of Florida, Gainesville. He's currently in Austin, Texas. Thank you, Rich.
Sure enough, always a good time.
I'm Vincent Racaniello. You can find me at virology.ws. I'd like to thank the American Society for Virology, the American Society for Microbiology for their support of TWiV, Ronald Jenkins for the music, and Jolene for the timestamps. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.